Hi guys, it's me, Professor D, and welcome back to my YouTube channel. On this video, we're doing another Kahoot. This is actually going to be a part 2 of the alternate type question format. I already did part 1, and of course, this Kahoot is not going to nearly have all of the alternate types because it really just does not support that platform really doesn't support those kind of types, but it does have the one where you can drag and drop, fill in the blank, select all that apply. And so those are the type of questions that I will be covering on this Kahoot. Before we get started, I want to do a little bit of house cleaning. So we're in the beginning of August, and this is the last month of my vacation that I've enjoyed so much, but it's coming to an end. I come back in September. And so I want you guys to know that I have opened up my calendar. I've opened up my calendar for private one-on-one tutoring sessions. I've opened up my calendar for Next Generation NCLEX reviews, part 1 and part 2. I've opened up those dates for September. Listen to me. If you need to sign up for a private tutoring session or review, do that now because I book very quickly. Remember, there's only one of me and a whole bunch of you guys, right? And there are only so many hours in a day. So even if you don't find the date or time that you need, I encourage you to go ahead and book whatever you find and then keep checking to see if you can reschedule, because again, I book very quickly and there's just nothing I can do about that. All of that is going to start in September because I'm still enjoying the rest of my vacation this month, but I did want you guys to know because by the time September arrives, I'm going to be completely booked. I can tell you that for a fact. Please don't forget to check out my website, nexusnursinginstitute.com. There's plenty of resources, audio lessons. I was going to tell you sign up for private tutoring, but again, that doesn't start until September, but there's plenty of things that start next month, but they're I cannot speak. There are audio lessons and also videos that you guys can check out. Plenty of information on my website. You guys can find me covering a variety of nursing topics across my social media platform. My handle's the same everywhere, Nexus Nursing. So be sure to check me out on Facebook, on Instagram, on TikTok, and of course here on YouTube. I feel like there's something. Oh, yes. I mentioned this in another video and it's coming soon, but I'm going to have a campaign that I'm going to be starting. I have a Nexus Nursing test bank that I'm putting together for you guys to prepare for your boards. Eventually, they're going to be questions that will actually prepare you if you're still in a nursing program, depending on what semester you're in. But again, I got to walk before I can run, right? So I'm going to start off with questions, just really preparing you for your boards. And I'm going to choose 50 students to be my beta testers. So it's going to be a free membership. You're going to go through it. Let me know what you think. Let me know the changes you'd like to see me make. And I also will but I'll provide once a week meetings to go over your struggles, what you need help with, what you don't understand, what you'd like me to explain, and you can kind of pick my brain before you go take your boards. I'm going to choose 50 students for this. 25 of them are going to be LP and LVN students, and 25 are going to be RN students. I'm not sure how I want to make this campaign/contest, so I'm still kind of thinking about it in my mind, but just keep a heads up and keep your eyes open for information regarding that soon to come. And guys, without any further ado, let's get started. Alternate type, part 2. First question. All right, your patient's magnesium level is 3.8 milligrams per deciliter. You'd most likely expect to note what? Would it be tremors? Would it be tachypnea? Would it be respiratory depression? Or would it be no clinical manifestations because nothing's wrong? What do you guys think? Let's talk about this because this is so crazy. A lot of you guys on the live chose tremors, and most of you guys on this Kahoot chose tremors. So let's talk about it. Magnesium, guys, magnesium will cause muscle relaxation, right? So the more magnesium you have, the more the muscles are going to be relaxed. And the less you have, the less those muscles are going to be relaxed. So it's going to be important that you understand the therapeutic range for magnesium. Now, if you look at the screen, it says magnesium is 3.8, but what is a normal value? It's 1.8 to 1.6, 1.8 to 2.6. The normal magnesium value is about 1.8 to 2.6. This patient's is all the way at 3.8. That means it surpassed the normal value. So if I told you that magnesium will cause muscle relaxation and they have way more magnesium than they're supposed to, how are they going to have tremors? If you have tremors, what's the muscles doing? It's contracting a lot. This patient has relaxation. It's going to be the opposite. We're going to see respiratory depression. Think about it. Those respiratory muscles are what contracts and expands and makes you be able to breathe, right? So we're going to see relaxation, respiratory depression. We're not going to see tremors. We're not going to see tachypnea. What is tachypnea? Increased respirations. Respiration is supposed to be about 12 to 22. You'd see respirations at 24, 26, whatever. But no, this patient's magnesium levels are high. And last, no clinical manifestations. 15 people chose this answer. Rule of thumb, when you're sitting down in front of your test and you get a question and you have no idea what the answer is, assume that something is wrong. There's a reason you're sitting down to take a test, right? Assume that something is wrong. Very rarely. It happens where you'll get a test question and all you got to do is document because there's nothing wrong. You don't have to do a nursing intervention, but very, very rarely, right? There's usually always something you need to do because something's wrong. That's the whole reason you're taking the test. They want to see what you know. How are you guys doing on the live? How do you join? Oh, I'm sorry. I forgot to tell you guys to please put the code to get in. Can you guys please put that in the comments in the post so anyone that comes in, they'll know the code to get in is 246-3419. Thank you. Go ahead, type that in for me, guys. 246-3419. All right, guys, next question. Okay, type in your answer. You have an order. You're supposed to give 50 milliliters of normal saline to infuse in 30 minutes, and the drop factor is 15 drops per ml. How many drops are you going to give? The order is to give 50 milliliters, and you're supposed to infuse that for 30 minutes. And your drop factor is 15 drops per ml. How many drops per minute are you going to give? So type in your answer. Your answer should just be a number. Martina said, what's the answer? You got to wait, Martina. You guys are doing great on the live. Uh-oh. 5, 7, 100, 450, 0.3. Oh, you guys are killers. You guys are killers. You guys killed your patient. Okay, 25 of you guys. So a quarter of you guys got the answer correct and you put 25. 25 is the answer. You're going to give 25 drops per minute. Here's what's so crazy. On the live, a couple of you put 2.5 instead of 25. You better be careful with that decimal. That decimal will completely change your answer, and that decimal will turn you into a killer. You will go to jail. You will lose your license. All right. And I saw some people on the live, they added a 0 instead of 25, they put 250. You're not a murderer. You're going to give 25 drops per minute. And so let me explain to you how you do this math. When it comes to drip factor, I promise you, it's so easy. This is the formula. I want you to write it down if you don't know what the formula is. The formula is you're going to multiply your volume times your drop per minute all over time in minutes. Your volume, the volume of fluid, times your drop per minute all over time in minutes. What do I mean by that? You're going to multiply your volume, your 50 milliliters, times your drop per ml, I should say, which is your 15. So you're going to do 50 times 15 all over time in minutes. How many minutes? 30 minutes. What if instead of 30 minutes, I told you 2 hours? So the question remains the same, but instead of 30 minutes, it said 2 hours. How would you set that problem up? You would do your volume, 50, times your drops per milliliter, 15, all over 2. Because if I told you 2 hours, you do all over 2 times 60. Why 60? There's 60 minutes in an hour. So if the question gives you the time in hours, you're going to multiply that times 60. But if they give it to you in minutes, all you got to do is plug that number in. There's nothing extra. Again, volume times drops per minute all over time in minutes. That's it. Okay. If you have any issues with dosage calculations, you can go to my pharmacology playlist or my fundamentals of nursing playlist on YouTube. And I have plenty of videos where I practice these type of problems, and you can see me with my pen and pencil, and you see me actually working out the problem. I'm old school. Back when I was in the nursing program, we weren't allowed to use calculators, so you had to do everything by head. All right. So you'll physically see me working everything out, and you can follow along. All right, what's your priority for a patient admitted with acute pancreatitis and controlled hypertension? That's all the information we have. Acute pancreatitis and controlled hypertension. What's your priority? Control the nausea, control the pain, control the blood pressure, or control the oxygenation. All we know is that the patient is admitted with acute pancreatitis and controlled hypertension. Okay. I'm so happy that most of you guys chose the correct answer, because this was a trick question. And NCLEX does this too. They will throw oxygen, airway, breathing in an answer choice just because they know that as students, the minute you see one of those, you're going to jump on it and not use your critical thinking skills. I wanted to see if you guys were going to do that. So I'm very proud of you. Most of you guys chose the correct answer. Most of you guys did the same thing on the live as well. Okay. All right. Good job. Why? Because we know, let's look. All I told you, what the patient came in with acute. The minute you see acute before a diagnosis, unless that patient's damn near dead, that's going to be our problem, right? Because remember, our priority is always what's immediately happening to the patient right now. So the fact that we saw acute, we know that's what's immediately happening to them right now. We know that's going to be our issue. Acute pancreatitis and controlled hypertension. So for those who chose, 14 of you guys chose control the blood pressure. Why? The blood pressure is controlled. I just told you they have controlled hypertension. Why is the hypertension going to be our priority if that's controlled? Our priority is always going to be what's wrong in the moment. And what's wrong in the moment is pancreatitis. Pancreatitis. I didn't tell you that the patient was having acute exacerbation of asthma or acute exacerbation of COPD or something something else that should make you think of the patient's airway. So it would not have been oxygenation that 15 of you guys chose, but we know when it comes to pancreatitis, what happens? That pancreas is inflamed. It is extremely painful. So absolutely controlling pain. Winnie Brown 891 says, shaking my head. Let's move on. All right. Type in your answer. This is what's going on with the patient. Their temperature is increased. Their pulse is increased. Respirations are increased. The O2 sat is normal. You're seeing nausea, vomiting. Patients got severe abdominal pain. They're dehydrated, and the colon sign is positive. What are you suspecting? What diagnosis do you suspect? Again, fever, the temperature's up. Tachypnea, tachycardia, decreased blood pressure, hypotension. The O2 sat's normal. Patient also has severe nausea, severe abdominal pain. They've got nausea, vomiting. They're dehydrated, and the colon sign is positive. What diagnosis would you suspect? Nashoni, I got an answer for you. We're going to talk about this. Appendicitis, I don't know, peritonitis, pancreatitis. All right. So it's acute pancreatitis. Now let's talk about this because Nazoni, you said dehydration. And I saw a couple of other answers. I want to show you, okay, I'm seeing hemorrhage, shock. When you see these type of questions, here's how you're going to differentiate. Increased temp, okay, maybe. Dehydration, because the temp can go up with that, right? Maybe. Increased pulse respirations, yep. Decreased blood pressure, maybe. And with the hemorrhage, yep. With the decreased blood pressure, increased pulse, increased respirations, yep. That could be hypotension, right? But that would not explain the severe abdominal pain unless we suspected maybe the patient had some type of trauma, which it doesn't say here, right? Let's keep going. I told you the patient is dehydrated. The word dehydration is right here. So why would that be the diagnosis that you would suspect when I already told you that we know that the patient's experiencing that? Here's your key, Cullen sign. Ali said perforation in bowels. Cullen sign. That is your key. That is what should have made you know that, okay, we're talking about pancreatitis and not anything else, right? That positive Cullen sign, that's that bluish color you see around the umbilical area. That lets us know that's what retroperitoneal bleeding from what? Most likely acute peritonitis. That was your key to let you know what you should be suspecting. Can someone send the Kahoot pin, please? The Kahoot pin is 246-3419. 246-3419. Next question. All right, this is a select all that applies. It says, which symptom would you expect to assess in a patient that is dehydrated? Select all that applies. Increased temperature, decreased temperature, tachycardia, bradycardia, hypertension, hypotension. Which symptoms would you expect to see in a patient that's dehydrated? And I accidentally gave you the answer to one of them in the last slide. So I hope you remember what I said. Select all that apply. Thank you, Lady B. The code is 246-3419. 246-3419. Okay. This is what you expect to see. As the patient is becoming dehydrated, increased temp. When you're dehydrated, your body's going to try to conserve the fluids that you have. Include sweating. Sweating helps cool you off, right? So we may see the temperature go up. The heart is going to try to compensate. You're going to see the heart rate go up. Heart rate's supposed to be 60 to 100. You'll see it higher than 100. Hypotension, blood pressure down. Your body's trying to conserve the fluid that it has. So what happens is we're going to see the blood pressure go down because your body's going to start shunting the much needed oxygen, vitamins, mineral, nutrients, all that good stuff that's carried in the blood. It's going to start shunting it to your vital organs. Right? It's going to start shunting it to your heart, to your brain, to your kidney, to your spleen. So when you take the patient's blood pressure, it's going to be down. When you look at that patient, their skin's going to be dry. They're going to have dry mucous membranes. They're going to have flat jugular veins. Make sure you guys know those signs and symptoms of infection. Select all that apply. All right, so your patient with COPD exacerbation is on high-dose steroids. Which signs and symptoms would you expect to note in this patient? Dyspnea, fever, cough, hyperglycemia, an O2 sat less than 91% on room air, chest pain. Your patient with COPD exacerbation is on high-dose steroids. What clinical manifestations would you expect to note in this type of patient? Oh, guys, if you need one-on-one tutoring, my calendar's open. I don't remember if I told you that or not. I feel like I did. Okay, let's talk about it. Dyspnea, difficulty breathing. Yes. Why? They've got COPD exacerbation. So this patient's got bronchitis, they've got emphysema, whatever's going, it's exacerbated. They're going to have difficulty breathing. Yes. Cough. Yes, we see that with COPD. Absolutely. And it's exacerbated. O2 sat being less than 91% on room air. Yeah, correct. They're going to need oxygen, low flow oxygen, but they're going to need oxygen, right? Because once that O2 sat hits 91 or less, that means the patient's in what? Respiratory distress. We expect to see that on a patient, in a patient with COPD that's having an exacerbation. Fever? No. COPD exacerbation will not cause a fever. Them being on steroids will not cause a fever. Steroids can mask the signs and symptoms of infection, right? So the patient may have an infection and we don't see the temp go up because of the steroids, but the steroids will not cause a fever. So that's wrong. Hyperglycemia, absolutely. Why? Not the COPD. The COPD doesn't cause the high blood sugar. It's the steroids. Steroids can turn you into a diabetic, right? What are the four things we know about steroids? The minute you're looking at a test question, it tells you that the patient's on steroids. These are the four things. Oh, why does it look like I only have 3 fingers? Whatever. These are the four things that need to be going through your mind. Number one, hyperglycemia. Steroids are very sugary. They can turn you into a diabetic. Number two, infection. Steroids decrease the inflammatory process in the body so they can mask the signs and symptoms of infection. It doesn't cause an infection, but it can mask those symptoms. So you're going to have to assess your patient a lot more closely. And a slight elevation in temperature is a big deal because it may mean that the patient has a big infection, right? You're going to be looking at the temperature. You're going to be looking at the WBCs. You're going to be looking at the ESR. You're going to be looking at the CRP. You're going to be looking, if the patient has a wound, you're going to be checking to make sure it's not mucopurulent. You're going to want to make sure there's no foul odor. You're going to look at the site. You want to make sure there's no redness, no inflammation, all that good stuff, all those signs and symptoms of infection, you're going to monitor much closely. So I went over two. I have two more to go over with you. Steroids, sugar, infection. Oh, ulcers. Steroids are very, very, very hard on the stomach. That's why you never give steroids on an empty stomach. You have to give it with food because steroids can cause the patient to have a stomach ulcer. And God forbid that ulcer starts to bleed. Now we got a bigger problem on our hands. And the fourth thing you have to be concerned whenever patients on steroids is osteoporosis or bone fractures. And the reason for that is steroids cause the bones to be porous. If the bones are porous, the patient is going to be at higher risk for fractures. We don't want the patient to have fractures. So make sure you know those things, four things when it comes to steroids. Select all that applies. All right, your patient just had abdominal surgery and you note evisceration. Which action would be contraindicated? So what are you not going to do? Here's your options. Place the head and body flat down with the knees flexed. Put on sterile gloves and gently reinsert the protruding bowel. Provide the patient with ice chips or small sips of water. Place a sterile warm saline soap dressing over the wound. Notify the healthcare provider immediately and prepare the patient for surgery. Which action would be contraindicated? In other words, which action would you not perform under this specific circumstance? What would you not do? Okay, talk about it. The first one, 56 of you guys got this correct. We would not place the head and body flat with the knees flexed. We're not going to do that. What we are going to do, we're going to elevate that head of the bed 15 to 20 degrees. The patient will be supine. They're going to be on their back, but we're going to elevate the head 15 to 20 degrees. But guess what? Their knees, yeah, they're going to be flexed. That part is correct. And the reason we do that, guys, we want to prevent stretching of the tissue. Number one, we want to prevent stretching of that tissue. And number two, we want to decrease the pressure on that area. So that's why the head of the bed is going to be elevated 15 to 20 degrees, but that patient absolutely will be on their back and their knees are going to be flexed because, again, we want to decrease stretching of that tissue and prevent more pressure on that site. Next, put a sterile glove and gently reinsert the protruding bowel. We absolutely are not going to do that. Look how I tried to trick you. I said gently reinsert. I don't care if I said gently or kindly or whatever. You're not going to reinsert anything. You're going to go. Do you understand what's happening here? If the patient has evisceration, that means, okay, they had a wound and now their guts, their bowels, their abdominal organs, whatever it is protruding out, is sticking out. And you trying to tell me that you're going to put on sterile gloves and just gently push their guts back in their body? You're a killer. You're going to lose your license. Absolutely not. We're not going to do that. Next, 60 of you guys chose this as a correct answer. Provide the patient with ice chips or small sips of water. That's right. That's contraindicated. We're not going to do that. Why? Because any patient that has evisceration, they're going into surgery. They're going to have surgery to get their guts back into the body in the way it's supposed to be, right? And we know before surgery, the patient's what? NPO. We're trying to decrease the risk of aspiration. So we're definitely not going to do any of those first three. Now look at the other three choices. They're not chosen because they're good answers. These are things that we would do. Placing a sterile, warm saline soaked dressing over the wound. Yes, because we don't want that wound to dry out. We don't want to cause tissue death. So that's good. Next, notify the healthcare provider immediately. Let me tell you something. When it comes to the rupture of an organ, when it comes to evisceration, so organs or body parts sticking out that patient's body, you're calling the healthcare provider. At that point, there's nothing you could do for that patient. It's between their surgeon and God. So you better believe, yes, you're calling the healthcare provider immediately because that patient's going to have to be rushed into surgery. And last, prepare the patient for surgery. Absolutely, if we want them to live. Are you guys doing on the live? When she says, let me tell you something, she means business. Yeah, when I'm upset with my kids, I say, let me tell you something. They straighten up right away. That's true. You're right. All right. Next question. Prioritize the order in which you would assess your patients. So here's the 4 patients. Which one would you see? First, second, third, fourth. Here are the patients. You have a 27-year-old patient with an order to insert an NG tube. Then you have a newly confused patient, 73 years old, diagnosed with thrombophlebitis. Then you have a 51-year-old patient that expresses anxiety about an upcoming procedure. And last, you have a 47-year-old patient requesting pain meds, and they're reporting a pain at the level of 6 out of 1 through 10. Who are you going to see first? So take your mouse and drag. You're just going to drag and drop, put it in order. Who you're going to see first, second, third, fourth. The patient that needs an NG tube, the patient with thrombophlebitis, the patient with anxiety, the patient requesting pain meds. Go ahead and put it in order. It's more than one answer. You got to put in order. You got to let me know which order all of them are going to be seen. Okay, only 22 of you guys got this correct. Let's talk about this before I even go over the correct answer choices. Whenever you're asked to prioritize, here's how you have to think. You have to think of what's going to kill my patient the fastest or keep them alive the longest, right? And so anything that is new happening to your patient, if it's new and it's bad, that's definitely going to be a priority. So if you had a patient that was previously awake, alert, oriented, all of a sudden they're confused. All of a sudden they're lethargic. All of a sudden they're drowsy. All of a sudden they think they see their grandma flying across the room. That's a change. It's an acute change and it's not for the good. So you have to assess that patient to try to figure out what's going on with them. You have to get information to give to the healthcare provider, right? So out of the list, the first patient is going to be a ding, 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 newly. That's your first red flag. Something's new. If a patient has a chronic condition, they've had it forever. Not that we don't care, but they had it forever. Why are we running to them first? We're running to the person that has a new change for the bad. Okay, so that's your first red flag. A newly confused. That's the next red flag. When a patient's confused, something's going on with their brain. Can you survive without a brain? No, you can't. Maybe they've got infection. Maybe they're hypoxemic. Maybe they had a stroke. Maybe there was a pulmonary embolism. We don't know what the issue is. But if a patient is suddenly confused, hello, red flag. So we got 2 red flags already. And I put it as an older patient to throw you off. Because many times as students, you think, oh, well, it's an older patient. They're supposed to be confused. No, they're not. No, they're not. Unless the patient has dementia, Alzheimer's, or some type of cognitive deficit, it doesn't mean they're supposed to be confused, right? Being older doesn't equal confusion. And then I told you they're diagnosed with thrombophlebitis. So a patient has thrombophlebitis. Now, all of a sudden, they're suddenly confused. Most likely, what's going on? A stroke, PE, something's happening that the brain's not getting enough oxygen. So that's going to be the first patient. Next, a 47-year-old patient post-op requesting pain meds, pain at a level of 6. Why is this our next patient? Because something's wrong. They just came from surgery. You come from surgery, you're going to be in pain. They're asking for pain meds. They have pain level 6. Something's wrong because the other 2 patients, there's nothing actively wrong with them. Look at the next one, a 27-year-old with an order for an NG tube. There is nothing going on with them. They just need an NG tube. And last, you have a patient with anxiety. Well, Professor D, anxiety, that's something wrong. How come the anxiety isn't higher on the list? I'm so happy you asked. Anxiety, anger, frustration, even patient teaching, that's on the top of Maslow's hierarchy of needs. All of our priorities going to be on the bottom. Priority, such as confusion, lethargy, hypoglycemia, severe dehydration, fluid electrolyte abnormalities, a seizure, myocardial infarction, abnormal vital signs. All of those things are our priority. That belongs on the bottom of the pyramid. But at the top, the patient's feelings and patient education, that comes last. Why? We care about the patient's physiological integrity. We want to make sure nothing is endangering their life. That's what comes first. So the first 3 can possibly endanger that patient's life in some way. That's why they come first, and last is the anxiety, because there's nothing physically wrong with that patient. The one right before that patient, the patient needs an NG tube. Well, something's physically wrong with them. Otherwise, they would need the NG tube. That's why the NG tube came before the patient with anxiety. The website is called, it's Kahoot.it, Kahoot.it. The code to get in is 246-3419. 246-3419. Next, put in order. You're giving IV antibiotics, and within 5 minutes of giving the antibiotics, your patient develops dyspnea, they start to wheeze, you hear stridor. What are you going to do? List your actions in order. You're giving antibiotics, and within 5 minutes of the IV infusion, your patient develops dyspnea, they start to wheeze, and you hear stridor. What are you going to do? Put it in order, guys. Take your mouse and move the answers in order from your first action to your last. Okay, let's talk about this. Only 24 of you guys got this correct. Here's what we're going to do. Whenever you're giving a patient an infusion and you suspect the infusion is harming your patient because you gave the infusion and within a couple minutes they start having these clinical manifestations, the first thing you always do is what's harming the patient. So the first thing we're going to do is turn off the infusion. Turn it off. Think about it. If you're pouring poison into a patient because it's harming them, so at this point we might as well consider that antibiotic to be poison, right? Poison is going into your patient and you're screaming, help, somebody help me, the whole while that poison is still going into the patient. You're a killer, right? So the first thing you're going to do is stop the poison. Whatever it is that's harming your patient, you're going to stop that first. Stop what's harming your patient. Next, you scream for help. Because guess what? The only way you were able to have another nurse set up the ordered emergency medication while you assess your patient is because you screamed for help and somebody else was in the room with you. Right? And of course, last, you're going to call the healthcare provider because while that other nurse was setting up another line to administer the emergency medications, you were assessing your patient so you can have information to give to the healthcare provider. Okay? Cece says that makes sense. All right. That's how I want you guys to think. Don't worry, Lala. A lot of people mixed up the last two. That's why I explained it the way I did. And that's how you guys have to think when you guys get these type of questions. All right, put it in order. Prioritize the patients you would assess. Here's your patients. You have a patient with pneumonia scheduled for their next dose of antibiotics, IV antibiotics. You have a teenager waiting for stitches on the arm because it got bit by a dog. You have an adult post-mastectomy that has to be taught how to change her dressing. And last, you have a toddler with a temperature that increased to 103.6. Who are you going to see first? Who are you going to see second? Who are you going to see third? And who are you going to see fourth? Pneumonia that needs IV antibiotics. A teenager that needs stitches from a dog bite. A post-mastectomy that needs to be taught how to change her dressing. And then a toddler whose temperature increased to 103.6. I'm very proud of you guys. Okay, 42 of you guys got this correct. The first one is a toddler. A toddler's temp. Look at this word. What does it say? Increased. There's been a change, and the change is not for the good. I'm going to say this a million times. When you see a change and it's not for the good, that's going to be a priority. And not only has increased, look what it increased to 103.6. You want to know who is most vulnerable when it comes to infections and risk of dehydration? The very young and the very old. 103.6. You are running, you are sprinting down the hall to that patient. Right after that is your patient with pneumonia. The patient's got an infection in the lungs. Can you live without your lungs? No, you can't. They need to breathe, right? So that patient that has that pneumonia, that infection in the lungs that needs antibiotics, that's who you're going to next after you assess the toddler. After that, the teenager that's waiting on stitches. Where's the stitches? It's on the arm. Are we suspecting any vital organ is in trouble like that toddler? Right? Vital organs are in trouble. Pneumonia, vital organs are in trouble, but a teenager with a bite from the arm, no vital organs, so they could wait. And then last, again, is the patient that needs teaching. Teaching, feelings, emotions, all of that comes last. You always have to take care of the patient's physiological integrity before you worry about anything else, okay? That's right. Tilda Doss said, life before limb. We care about the patient's life before the limbs. Very good. All right, last question. The definitive diagnosis of peptic ulcer disease would involve what? Would it be a urea breath test? Would it be an upper endoscopy with a biopsy? Would it be a barium contrast? Or would it be a metallic test? Very good. Most of you guys got this answer correct. Upper endoscopy with biopsy. So you expect the upper endoscopy to be performed. You're not going to do it, but you're going to assist with it. You expect that to be performed. It helps to visualize, right? That mucosa, see if it's ulcerated, and then you get the biopsy, and that biopsy is going to tell you, okay, are we dealing with peptic ulcer disease? Or is it cancer? Or is it H. pylori? Like whatever, that biopsy is going to tell us what we're dealing with. Um, the urea breath test, that's for H. pylori. Um, the barium contrast. If a patient ever has a barium contrast, you see in the question, they tell you the patient has a barium contrast. Automatically, you better be thinking of fluids. We need to flush the patient's body to get that barium out. Okay, so the patient's going to get fluids, and you're going to check them for constipation because it's very constipating. So you're going to give them lots of fluids, lots of fiber. Metallic test, that's another test for the H. pylori. The only correct answer here, guys, is the upper endoscopy with biopsy. Again, the biopsy, that is what's going to tell you definitively if you're dealing with peptic ulcer disease or maybe if you're dealing with something else. And guys, that was our last slide. Let's see how you did.